Bismillahirrahmanirrahim. Today I'm going to present the latest updates for pediatric basic and advanced life support. We have lots of updates. Some have been updated, others are new recommendations by the American Heart Association. All the topics I'm going to talk about are being published in the highlights and guidelines for the CPR and ECC committee. For the introduction, these highlights summarize the key issues and changes in the 2020 American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care. The 2020 guidelines are a comprehensive revision of the American Heart Association's guideline for adult, pediatric, neonatal resuscitation, education science, and systems of care topics. They have been developed for resuscitation providers and American Heart Association instructors, so it should be known by the instructors and providers as well, to focus on the resuscitation science and guidelines recommendations that are most significant or controversial, or those that will result in changes in resuscitation training, practice, and to provide the rationale for the recommendations. In pediatrics mainly, more than 20,000 infants and children have a cardiac arrest each year in the United States. Despite increases in survival and comparatively good rates of good neurologic outcome after pediatric intra-hospital cardiac arrest, survival rates from pediatric out-of-hospital cardiac arrest remain poor, particularly in infants. Recommendations for pediatric basic life support and cardiopulmonary resuscitation in infants, children, and adolescents have been combined with recommendations for pediatric advanced life support in a single document in 2020 guidelines. The causes of cardiac arrest in infants and children differ from cardiac arrest in adults, and a growing body of pediatric specific evidence supports these recommendations. So now we'll go through the major new and updated recommendations. We'll go one by one. Changes to the assisted ventilation ratio. Risk breathing recommendations. In the old guide, if there is a palpable pulse, 60 per minute or greater, but there is an adequate breathing, we'll give rescue breathing at a rate of about 12 to 20. I mean, every 3 to 5 seconds until spontaneous breathing resumes. So that was the old guidelines. How about the new guidelines? The new guidelines states that in infants and children with a pulse, but absent or inadequate respiratory effort, it's reasonable to give one breath every 2 to 3 seconds. I mean 20 to 30 breaths per minute. This is going to improve the outcome and the long-term prognosis or neurologic sequelae. So we'll give ambu bagging at a higher rate, 20 to 30, compared to the previous guidelines, 12 to 20. How about the assisted ventilation ratio, rate to ventilation rate during CPR with an advanced airway? In the old guidelines, if the infant or a child is intubated, we will ventilate at a rate of one breath every 6 seconds. I mean 10 per minute without interrupting chest compressions. So he's having an advanced airway, I mean intubated. So no need to synchronize between chest compressions and bagging. We will bag one breath every 6 seconds. I mean 10 breaths per minute. That was the old guidelines. But for the new guidelines, we're performing CPR in infants and children with an advanced airway. It may be reasonable to target a respiratory rate of one breath every 2 to 3 seconds, 20 to 30 per minute, accounting for age and clinical condition. Rates exceeding these recommendations may compromise hemodynamics. So we should give bagging at a higher rate, 20 to 30 per minute. How about the cuffed tubes? In the old guidelines, both cuffed and uncuffed tubes are acceptable for intubating infants and children. In certain circumstances, with poor lung compliance, high airway resistance, or a large glottic air leak, a cuffed ET tube may be preferable to an uncuffed tube, provided that attention is paid to ensure appropriate ETT size, position, and cuff inflation pressure. So any of our residents can tell me what is the appropriate ET tube cuff for a certain age?
It will be age, yeah, age divided on 4, plus 4 for uncuffed and plus 3.5 for the cuffed tube.
Excellent, excellent. So for cuffed tube, quarter the age in years plus 3.5. If it's uncuffed, it will be quarter the age in years plus 4. So the new recommendation states that it's reasonable to choose cuffed tube. So our first preference is a cuffed tube in the new guidelines over the uncuffed tube for intubating infants and children. When a cuffed ET tube is used, attention should be paid to ETT size, position, and cuff inflation pressure, which should be less than 20 cm². Cricoid pressure during intubation. In the previous guidelines, there is insufficient evidence to recommend routine application of cricoid pressure to prevent aspiration during endotracheal intubation in children. But in the updated guidelines, the routine use of cricoid pressure is not recommended during endotracheal intubation for pediatric patients. They also emphasized on the early epinephrine administration. In the old guidelines, it's reasonable to administer epinephrine in pediatric cardiac arrest, but they did not specify the time period. When should I give the epinephrine? Or after CPR, after how much time should I give the first dose of epinephrine? But in the new guidelines, for the pediatric patients in any settings, it's reasonable to administer the initial dose of epinephrine within 5 minutes from the start of chest compressions. So within 5 minutes of chest compressions, we should give the first dose of epinephrine. How about the invasive blood pressure monitoring to assess CPR quality? I mean the arterial blood pressure monitoring. That's what's meant by invasive. For patients with invasive hemodynamic monitoring in place at the time of cardiac arrest, it may be reasonable for rescuers to use blood pressure to guide the CPR quality. Just to look at the wave and to guide your CPR quality. But in the updates, they recommended that for patients with continuous invasive arterial blood pressure monitoring in place at the time of cardiac arrest, it's reasonable for the providers to use diastolic blood pressure to assess CPR quality. So they mentioned specifically the diastolic blood pressure. Any of our residents can tell me why you are meant by the diastolic pressure rather than the systolic?
Is it because the diastolic reflects the coronary perfusion?
So, excellent. So the diastolic perfusion occurs mainly during diastole. So we are concerned about diastolic pressure rather than the systolic. So if I have the chance of an arterial blood pressure monitoring, so it's reasonable for us to use the diastolic blood pressure to assess the CPR quality. Detecting and treating seizures after the ROSC. What is ROSC?
Return of spontaneous circulation.
Excellent. So once I have a perfusing rhythm or spontaneous circulation, what should I do? What should I look for?
Ahmad, we need to Ahmad, we need other to contribute, not only Suleiman. من سليمان اللي بيرد؟
لا أنا نواف شصيم R2.
والنعم نواف. طيب نبغى الكل يشاركوا من الشباب. ها كمل يا أحمد تفضل.
طيب. In 2015, all the guidelines, an EEG for diagnosis of seizure should be promptly performed and interrupted and interpreted, and then should be monitored frequently or continuously in comatose patients after ROSC. The same anticonvulsant regimens for the treatment of status epilepticus caused by other etiologies may be considered after cardiac arrest. So we should aggressively control convulsions if there is any. So can any of our colleagues tell us why?
Not necessarily resident, يمكن تكون difficult question, لكن الزملاء في اليونت they should know about this one.
Maybe they didn't understand the question. You want to rephrase it or just verbalize it again, please, Dr. Ashry?
Why should we treat convulsions aggressively? Why should we prevent the patient to seize post cardiac arrest? What will happen if the patient is convulsing? What will happen to the brain blood supply?
The blood supply would decrease, so the oxygen would be decreased to a specific part of the brain.
Increase?
Excellent.
So if there is continuous seizure, there will be increase in the metabolic demands of those brain cells. And this will increase the secondary injury to the already insulted brain. So the main issue here, you want to prevent the secondary injury, correct? Excellent.
So in updated guidelines, when resources are available, continuous EEG monitoring is recommended for the detection of seizures following cardiac arrest in patients with persistent encephalopathy. It's reasonable to treat non-convulsive status epilepticus following cardiac arrest in consultation with experts. It's recommended to treat clinical seizure following cardiac arrest. So if the patient is seizing clinically, I have to treat it aggressively. If he's not seizing, but I have doubt of non-convulsive status, I should utilize my resources of continuous EEG monitoring. If any seizure activity is there, I have to treat it aggressively. I should follow the status epilepticus guidelines in my institute. So, evaluation and support for cardiac arrest survivors. It's a new guidelines, no old guidelines to update. So it's a new, it was not there before. It's recommended that pediatric cardiac arrest survivors be evaluated for rehabilitation services. They will need a multidisciplinary team follow-up from the neurologist, from psychiatrist, from the physiotherapist, occupational therapist, in case they have any sequelae. It's reasonable to refer pediatric cardiac arrest survivors for ongoing neurologic evaluation for at least the first year after cardiac arrest. So they may not manifest neurologic manifestations as soon. So I should keep the follow-up for at least 1 year, for the first year. So septic shock. How about the fluid boluses? Any of our colleagues can tell me, how about the fluid boluses in septic shock patients? What's the rate? What is the volume? When should I be cautious with fluid therapy in the initial 1 hour?
We start with 20 ml per kg. And in case of cardiac patients, 10 ml per kg.
So 20 ml per kg over how much time? Should I give it over 5-10 minutes? Should I give it over 20 minutes? Should I give
20
it over
minutes,
1
20
hour?
to 30 minutes.
Isn't it too long?
Fast as a bolus يعني should be given.
If septic shock, you should give it at fast, 5 to 10 minutes, unless unless I have a doubt that patient having cardiac lesion, isn't it? Or this patient in DKA, or I'm doubting intoxication, isn't it, as per PALS? So the fluid boluses in the old guidelines, administration of an initial fluid bolus of 20 ml per kg to infants and children with shock is reasonable, including those with conditions such as severe sepsis, severe malaria, and dengue. In the new guidelines, in patients with septic shock, it's reasonable to administer fluid in 10 ml per kg or 20 ml per kg aliquot with frequent reassessment. So each bolus, I have to reassess the patients for signs of volume overload, like increasing walls of breathing, crackles on the base, or palpable level. So each bolus, I have to reassess my patients for signs of volume overload. The choice of vasopressor. In the old guidelines, they did not specify a certain vasopressor, but in the new guidelines, they mentioned about these vasopressors. In infants and children with fluid refractory septic shock, it's reasonable to use either epinephrine or norepinephrine as an initial vasoactive infusion. In infants and children with fluid refractory septic shock, if epinephrine or norepinephrine are unavailable, dopamine may be considered. So still I can use the dopamine if I don't have the facility of epinephrine or norepinephrine infusion. How about the corticosteroid administration? In the previous guidelines, they didn't mention about the corticosteroid, but in the new guidelines, they stated that for infants and children with septic shock, unresponsive to fluids, and requiring vasoactive support, it may be reasonable to consider stress dose corticosteroids. Am I clear so far? How about the hemorrhagic shock? In the old guidelines, they didn't mention anything about the hemorrhagic shock. They managed shock in general. So, but in the new guidelines, they stated that among infants and children with hypotensive hemorrhagic shock following trauma, it's reasonable to administer blood products when available instead of crystalloid for ongoing volume resuscitation. Opioid overdose. Empiric administration of intramuscular or intranasal naloxone, which is an antidote for opioids to all unresponsive opioid-associated life-threatening emergency patients, may be reasonable as an adjunct to standard first aid and non-healthcare providers' BLS protocols. Advanced cardiac life support providers should support ventilation and administer naloxone to patients with a perfusing cardiac rhythm and opioid-associated respiratory arrest or severe respiratory depression. Bag mask ventilation should be maintained until spontaneous breathing returns, and standard advanced cardiac life support measures should continue if return of spontaneous breathing does not occur. In the updated guidelines for patients in respiratory arrest, rescue breathing or bag mask ventilation should be maintained until spontaneous breathing returns, and standard pediatric basic life support or PALS measures should continue if return of spontaneous breathing does not occur. For a patient with suspected opioid overdose who has a definite pulse but no normal breathing or only gasping, in addition to providing standard pediatric basic life support or PALS, it's reasonable for responders to administer intramuscular or intranasal naloxone. So here they prioritize the PALS measures. We can make no recommendation regarding the administration of naloxone in confirmed opioid-associated cardiac arrest. This is in the old guidelines. In the updated guidelines, for patients known or suspected to be in cardiac arrest in the absence of proven benefit from the use of naloxone, standard resuscitative measures should take priority over naloxone administration with a focus on high-quality CPR, compression plus ventilation. Patients with myocarditis. It's new. We don't have guidelines in the old 2015. So they mentioned that given the high risk of cardiac arrest in children with acute myocarditis who demonstrate arrhythmias, heart block, ST segment change, and or low cardiac output, early consideration of transfer to ICU monitoring and therapy is recommended. So such patients should be managed in an ICU settings. For children with myocarditis or cardiomyopathy and refractory low cardiac output, pre-arrest use of extracorporeal life support or mechanical circulatory support can be beneficial to provide end organ support and prevent cardiac arrest. Whenever the facilities are there, for sure. Given the challenges to successful resuscitation of children with myocarditis and cardiomyopathy, once cardiac arrest occurs, early consideration of extracorporeal cardiopulmonary resuscitation may be beneficial. Single ventricle. Again, it's another new one. So there are new guidelines for the septic shock, for the hemorrhagic shock, for patients with myocarditis, and for patients with single ventricle. Recommendations for the treatment of preoperative and postoperative stage 1 palliation. Stage 1 اللي هي Norwood BT shunt patients. All are new guidelines. Direct superior vena cava catheter and or indirect near infrared spectroscopy oxygen saturation monitoring can be beneficial to trend and direct management in the critically ill neonate after stage 1 palliation or shunt placement. In the patients with an appropriately restrictive shunt, manipulation of pulmonary vascular resistance may have little effect, whereas lowering systemic vascular resistance with the use of systemic vasodilators, with or without the use of oxygen, can be useful to increase the systemic delivery of oxygen. Extracorporeal life support after stage 1 can be useful to treat low systemic oxygen delivery to tissues. In the situation of known or suspected shunt obstruction, it's reasonable to administer oxygen, vasoactive agents to increase the shunt perfusion pressure, and heparin while preparing for catheter-based or surgical intervention. How about the second stage? Sorry, we are still in the stage 1. In the old guidelines, it's mentioned that neonates in a pre-arrest state due to elevated pulmonary to systemic flow ratio prior to stage 1 repair might benefit from arterial PCO2 of 50 to 60, which can be achieved during mechanical ventilation by reducing minute ventilation, increasing the inspired fraction of CO2, or administering opioids with or without chemicals. Chemicals, I mean the neuromuscular blockage. Can anyone of the attendee tell us why we will target higher CO2 in these patients? These patients having high pulmonary blood flow. What will do the high CO2 to the pulmonary blood flow?
Vasoconstriction.
Excellent, vasoconstriction. So vasoconstriction will
Then what will happen to the vasoconstriction? معلش خليه يكمل الجواب يا أحمد لو سمحت.
طيب اتفضل.
Vasoconstriction will decrease the pulmonary blood flow.
نعم صحيح.
So in the new guidelines for neonates prior to stage 1, repair with pulmonary overcirculation and symptomatic low systemic cardiac output and oxygen delivery, it's reasonable to target a PCO2 of 50 to 60. This can be achieved during mechanical ventilation by reducing the minute ventilation or by administering analgesia sedation with or without neuromuscular blockade. So we can handle the PCO2 through our mechanical ventilator. So the recommendations for the treatment of post-operative stage 2 اللي هي bidirectional Glenn shunt اللي هي cavopulmonary anastomosis, and stage 3 Fontaine palliation for patients in a pre-arrest state with superior cavopulmonary anastomosis physiology and severe hypoxemia due to inadequate pulmonary blood flow. Ventilatory strategies that target a mild respiratory acidosis and minimum mean airway pressure without atelectasis can be useful to increase cerebral and systemic arterial oxygenation. Extracorporeal life support in patients with superior cavopulmonary anastomosis or Fontaine circulation may be considered to treat low oxygen delivery for reversible causes or as a bridge to a ventricular assist device or surgical revision. Why they mention these recommendations in the new guidelines? As it's approximately 1 in 600 infants and children are born with critical congenital heart disease. Staged surgery for children born with single ventricle physiology, such as hypoplastic left heart, spans the first several years of life. Resuscitation of these infants and children is complex and differs in important way from standard PALS care. Previous PALS guidelines did not contain recommendations for this specialized patient population. These recommendations are consistent with the 2018 American Heart Association scientific statement on CPR in infants and children with cardiac disease. So how about the pulmonary hypertension? In all the guidelines, consider administering inhaled nitric oxide or aerosolized prostacyclin or analog to reduce pulmonary vascular resistance. In the updated guidelines, inhaled nitric oxide or prostacyclin should be used as the initial therapy to treat pulmonary hypertension crisis or acute right-sided heart failure secondary to increased pulmonary vascular resistance. Anyone can tell me any other measures to help in reducing the pulmonary vascular resistance?
Oxygenation, hyperventilation, keeping the alkalotic site, proper oxygenation, hyperventilation.
So the opposite of the previous, opposite of the previous patients who were having single ventricle pathology, and this single ventricle pathology patients, we should reduce the pulmonary blood flow. So we should target hypoventilation. So we should target higher CO2. The other way, or the opposite, for patients with pulmonary hypertension, we should aim for a lower PCO2. So we should provide careful respiratory management and monitoring to avoid hypoxemia and acidosis. So we should provide adequate oxygen. We should prevent acidosis in the post-operative care for children with pulmonary hypertension. For pediatric patients who are at high risk of pulmonary hypertension crisis, provide adequate analgesics, sedatives, and neuromuscular blocking agents. For the initial treatment of pulmonary hypertensive crisis, oxygen administration and induction of alkalosis through hyperventilation or alkali administration can be useful, while pulmonary specific vasodilators are administered. For children who develop refractory pulmonary hypertension, including signs of low cardiac output or profound respiratory failure, despite optimal medical therapy, extracorporeal life support may be considered. So we'll have algorithms and visual aids. They changed in the new guidelines. In the chain of survival, they added the sixth chain, which is recovery. A new pediatric chain of survival was created for the intra-hospital cardiac arrest in infants, children, and adolescents. A sixth link, this is for the recovery, was added to pediatric out-of-hospital cardiac arrest chain of survival and is included in the new pediatric intra-hospital cardiac arrest chain of survival. How about the pediatric cardiac arrest algorithm? The one on the right is the old algorithm, the one on the right of the screen. For patients with cardiac arrest, once the patient having asystole, we have to start the CPR within 2 minutes. In the new guidelines, they mention epinephrine as soon as possible. Once we detect asystole, so epinephrine should be ordered and should be administered within the first 5 minutes. So if it's unshockable rhythm, asystole or pulseless electrical activity, epinephrine should be prepared as soon as possible. Then while initiating the CPR. This is per the new guideline. Pediatric bradycardia with a pulse. Here, this one is the algorithm for pediatric bradycardia, the old one, 2015 algorithm. This one is the new one. I will have a bigger photo for it, sorry. Here it is. So patient with bradycardia with no signs, with signs of cardiopulmonary compromise, assess and support, maintain patent airway, breathing, cardiac monitoring. Then we'll start CPR if it's less than 60 per minute. Bradycardia, if it persists, we'll continue CPR, consider epinephrine, consider atropine for increased vagal tone or primary AV block. Then we should check the pulse every 2 minutes. If it's still bradycardia is there, we should go again for the should continue the CPR. I mean, the epinephrine every 2 to 3 minutes. Pediatric tachycardia with a pulse algorithm. This is the old algorithm for pediatric tachycardia with a pulse. They have separate pathway for the narrow complex tachycardia and the wide complex tachycardia. In the new algorithm, they combined both. I mean, once I have a patient with tachycardia, I will differentiate. Is there any cardiopulmonary compromise? Then I will look for the QRS complex. If it's narrow complex, it's mostly SVT, then I will follow the algorithm. If it's wide, so it's possible VTAC, then I will go for synchronized cardioversion. If I don't have signs of cardiopulmonary compromise, then I should go, is it narrow or wide? So they combined the two pathways of wide and narrow complex tachycardia in the new algorithm. So they added the checklist for components of post-cardiac arrest care. These components include oxygenation and ventilation, hemodynamic monitoring, targeted temperature management, neuromonitoring, electrolytes and glucose, sedation, and prognosis. So we are done with all the guidelines or all the updates for the 2020 guidelines. Then we'll summarize. I'm going to summarize my items now. Algorithms and visual aids were revised to incorporate the best science and improve clarity for pediatric basic life support and pediatric advanced life support resuscitation providers. Based on newly available data from pediatric resuscitation, the recommended assisted ventilation rate has been increased to 1 breath every 2 to 3 seconds. I mean 20 to 30 breaths per minute for all pediatric resuscitation scenarios, whether there is an advanced airway or no advanced airway. Cuffed ET tubes are suggested to reduce the air leak and the need for tube exchange for patients of any age who require intubation. So whenever it's available, we prefer the use of the cuffed ET tube. The routine use of cricoid pressure during intubation is no longer recommended. To maximize the chance of good resuscitation outcomes, epinephrine should be administered as early as possible, ideally within 5 minutes of the start of cardiac arrest from a non-shockable rhythm. Non-shockable rhythms in pediatrics will asystole and pulseless electrical activity. For patients with arterial lines in place, using feedback from continuous measurement of the arterial blood pressure may improve the CPR quality. And we should keep an eye on the diastolic pressure, as we have stated before. After return of spontaneous circulation, patients should be evaluated for seizures. Status epilepticus and any convulsive seizures should be treated aggressively. Because recovery from cardiac arrest continues long after the initial hospitalization, patients should have formal assessment and support for their physical, cognitive, and psychosocial needs. A titrated approach to fluid management with epinephrine or norepinephrine infusions, if vasopressors are needed, is appropriate in resuscitation from septic shock. On the basis largely of extrapolation from adult data, balanced blood component resuscitation is reasonable for infants and children with hemorrhagic shock. Opioid overdose management includes CPR and the timely administration of naloxone by either the lay rescuers or trained rescuers. Children with acute myocarditis who have arrhythmias, heart block, ST segmented changes, or low cardiac output are at high risk of cardiac arrest. So they should be transferred as soon as possible to an intensive care unit. And some patients may require mechanical circulatory support or extracorporeal life support. Infants and children with congenital heart disease and single ventricle physiology who are in the process of staged reconstruction require special consideration in PALS management. Management of pulmonary hypertension may include the use of inhaled nitric oxide, prostacyclin, analgesia, sedation, neuromuscular blockade, and induction of alkalosis or rescue therapy with extracorporeal life support. Any questions? We are done with our presentation. I hope we did it on time.